Okay, hello everyone and welcome back to my channel. My name is Rahma and this is the second video on our series where I help you get through first aid chapters, which can be daunting and difficult and intimidating to do on your own, and sometimes you just need somebody to read it for you. So I am going to take up this huge task and we're going to read these chapters together. If you've watched the previous video I've done on heme, I do apologize because the video quality, the sound was really, there was a lot of background noise and my mic just wasn't picking up my voice that well. So we are definitely going to re-record those videos, but for the time being, I am going to continue on with another topic and hopefully we can get more work done in the future. So for today, we are going to go through endocrine and I am going to highlight for you the points that are most important or the areas where there are a lot of questions that can come up on the exam. And usually how I know these things is because I read a chapter and then I cycle through 2 or 3 or 4 blocks, so then I have a relative idea of the things that get repeated or the key points that you want to know. So even though first aid is a very high yield book, there are sections that are more high yield than others, or different ways or techniques certain questions can be asked. So we're definitely going to go through that together as far as my battery will permit. So we've got about 2 hours and 24 minutes. So we're going to go, I don't know if I'll be able to finish all of endocrine in one video, but we are going to do our best to move thoroughly and quickly as possible. I am going to take some notes with the pen feature here, and we're going to highlight the most important words. And I'm going to try to zoom in as much as possible so you guys can follow along. I am using the First Aid 2020 book, so if you're using that one, that is the one that I'm using. Most of the books are relatively the same. I think there isn't really that much of a difference between them, so you can always follow along, and of course all the content typically is the same, so there's nothing wrong with that. So let's begin with endocrine. And endocrine is really like simple. It's very easy for the most part. You do have your main divisions, like you have your thyroid gland and its pathologies, you have your pancreas, you have your pituitary, and your parathyroid. So it's a good topic to start off from, because if you have your book divided based on systems versus basic principles, it might be a little bit intimidating to start right away with cardio, which I think is the first system topic, and that can be really intimidating to just put your foot into that. So endocrine might be a good place for you to start if you're just starting, by the way. So we're going to start off with thyroid development. So for thyroid development, all you need to know for thyroid development is that the thyroid gland is going to start off embryologically in this area here called the foramen cecum. So you could be asked, what is the embryological origin of the thyroid gland? So you might need to know that that is the foramen cecum, and the thyroid gland is going to keep on descending all the way into the anterior neck. Anywhere along this it can stop, and that can lead to a pathology, or this duct here that you see, this thyroglossal duct, can remain as a duct, and that can lead to another type of pathology. So let's highlight what is most important. You have the thyroid diverticulum arises from the 4th floor of the primitive pharynx and descends into the neck, as we've already said, connected to the tongue by the thyroglossal duct, which normally disappears, but it may persist as a cyst or the pyramidal lobe of the thyroid gland. The foramen cecum is the normal remnant of the thyroglossal duct. So if you get a picture of an adult tongue, the foramen cecum is here, and there's this line here that really differentiates the anterior 2/3 of the tongue versus the posterior third. And here you would have the foramen cecum. Most of the ectopic thyroid tissue sits in the tongue. So, like we said, it can continue. It's supposed to continue to descend into the anterior of the neck, but if it doesn't do that, it can get stuck anywhere along this pathway. So if that happens, typically the most common location you want to know is lingual thyroid. So that's important, lingual thyroid. And how this is going to present for you in the case file is you're going to get a child who has an upper respiratory tract infection, and suddenly they have difficulty swallowing. And the reason for that is because there is lymphoid tissue in this lingual thyroid, and that's going to swell or have hyperplasia when the patient is sick, and that's the reason for the difficulty swallowing. And the key thing you want to be aware of is just because the part of the thyroid gland is there, you shouldn't assume that some of it descended. That could be the only place where you have any thyroid tissue. So if you do remove a lingual thyroid, you have to consider that the patient may be hypothyroid, as that might be the only functioning thyroid tissue that this patient has. So that's the things you want to be aware of. The most common ectopic is the tongue, so that's lingual thyroid removal may result in hypothyroidism. Thyroglossal duct cyst presents as an anterior midline mass that moves with swallowing or protrusion of the tongue. So the key words of the moves with swallowing or protrusion of the tongue, those are actually our buzzwords for any thyroid or thyroid-related pathology. So anytime you have a clinical vignette of something that moves up and down with swallowing or protrusion of the tongue, you want to think of thyroid gland or a thyroglossal duct cyst. Those are the features of those pathologies. Thyroid follicular cells are derived from the endoderm, and thyroid follicular cells are derived from the fourth pharyngeal pouch. You may get a question on what are the derivatives. Now, the next thing is the pituitary gland. So if you remember the pituitary gland, you have, it kind of looks like this, and then at the very top here you have the hypothalamus, and you have the pituitary. The pituitary is divided as anterior pituitary and posterior pituitary, and you want to know what are the hormones that are produced here and what they do and their functions and how they work on a cellular level. So that's a lot of information and a lot of possible questions you can deal with. So if you're going to start with the pituitary gland, I recommend you go straight to the posterior pituitary. So that's neurohypophysis. So posterior pituitary is interesting because it only deals with two different hormones, and both of these hormones are not actually made in the posterior pituitary. They are made in the hypothalamus, and the paraventricular and the supraoptic nuclei. So you can highlight that. So they're made in the hypothalamus, and then they are stored in the posterior pituitary. And what carries them from the hypothalamus to the posterior pituitary are these neurons called neurophycins. So you can get a question that tells you what are the hormones secreted by the posterior pituitary, and you want to know that they are vasopressin, also known as ADH, and oxytocin. Then you can get asked, well, where are these hormones made? And you don't want to make the mistake of saying that they are made in the posterior pituitary, because they're not. They are made in the hypothalamus, they are stored in the pituitary, and they are carried from the hypothalamus to the posterior pituitary by these types of nerves called neurophycins. These are carrier proteins. And the posterior pituitary is derived from the neuroectoderm. So you have a variety of questions here. It's good to memorize this section, and it's fairly simple. The rest of the hormones are from the anterior pituitary, and the anterior pituitary makes them. So it secretes everything else that isn't oxytocin or vasopressin. So you have your FSH, LH, ACTH, TSH, prolactin, GH, beta endorphin, melanotropin. So from these guys, I can tell you that the most important thing you want to be aware of that you might skip over is that beta endorphins and melanotropins and ACTH, these three compounds are made from the same precursor called POMC. So POMC is what is the main derivative of these three compounds here. So whenever you have a pathology, take for example, if you have decreased cortisol, right, such as if you have decreased cortisol and adrenal insufficiency, right, you're going to have increased ACTH as a response. What's going to happen is that melanotropin, MSH, is also going to concurrently increase. And melanotropin, as the name implies, is going to increase melanin. It's responsible for melanin production. So you're going to have the feature of darkening of the skin in patients with adrenal insufficiency. So that is a way for you to understand the pathophysiology of something like adrenal insufficiency based on just knowing the fact that these three are derived from this POMC. So here you have the POMC derivatives are beta endorphin, ACTH, and MSH. Next you have the adrenal cortex and the medulla. So for the adrenal cortex and the medulla, you can be asked questions based on the histology. So you want to know your anatomy, you want to know your histology. So they might ask you zona glomerulosa, zona fasciculata, and zona reticularis, what is secreted in these areas, and you might want to be asked to identify that on a biopsy. So they'll have an arrow that points to this area, and they'll tell you, well, what's this area, and what is secreted here, and what's this area, and what's secreted there, and what's this area, and what's secreted there. And don't forget this area here, which is the medulla, and that is the chromaffin cells. So Let's start with the medulla, since that's the easiest thing to take a look at. You have your medulla, which is your innermost section here, and this is made up of chromaffin cells, and they secrete catecholamines, epinephrine, and norepinephrine. So the one disease you want to be aware of is pheochromocytoma, which is an increase in catecholamine secretion, and all of the symptomatology is going to be based on this, and we'll discuss that later when we get to the pathology. Like we said, you want to be aware of GFR. That's one way to remember it. GFR is zona glomerulosa, fasciculata, and reticularis. We can use this to help you memorize it. The deeper you go, the sweeter it gets. So if you start off with salt, sugar, and then this, you'll have an understanding of what is being secreted where. So zona glomerulosa is going to be salt, so salt is going to be aldosterone. Zona fasciculata is going to be sugar, so sugar is glucocorticoids, glucose, and then you're going to have your cortisol, and then your zona reticularis is your last one, and you're going to have the adrenal androgens coming out from that area. Next, you're going to have your pancreas. Pancreas is very simple. Most of us already know that you have your beta islet cells, which are going to secrete your insulin. You have your alpha cells, which are going to secrete your glucagon. And then you have your delta cells, which are going to secrete your somatostatin. With the pancreatic pathology, you can have a glucagonoma, you can have an insulinoma, or you can have decreased insulin, which is known as diabetes. And then you have the somatostatinoma, which one way to remember it, and I'm going to repeat a lot of these details so that we can memorize these things together, is that somatostatin, you want to think of it as somatostasis, so it's going to stop everything. So if I'm secreting somatostasis, I'm going to stop secreting pancreatic enzymes. I'm going to stop secreting insulin. You're going to have diabetes. I'm going to stop the contraction of the gallbladder. You're going to have gallstones. So that's the kind of clinical vignette involving a somatostatinoma. Next is your hypothalamic and pituitary hormones. You want to be aware of what they do, what is their function, and what any clinical notes you want to be aware of. So you have ADH, and we're going to discuss all these in details. But this is kind of like a brief overview of them. So you have ADH. So what does ADH do? So ADH, as the name implies, is antidiuretic hormone. So if you're antidiuresis, you want to absorb as much water as possible from the urine back into the plasma, correct? So we do that by inserting something called aquaporin 2 channels into the proximal convoluted tubule, and then we reabsorb all that water back into our plasma, so the urine becomes more concentrated. So we're going to increase the water permeability of the distal convoluted tubule, sorry about that, and the collecting ducts in the kidney, and increase water reabsorption. The stimulus for secretion is increased plasma osmolality. So you want to think of it as, if I have a lot of osmoles in my plasma, right, then it's concentrated. So how do you fix that? You want to dilute it a little bit. So one way to do that is to do the whole aquaporin channel insertion, reabsorb all that water, so then this can decrease the osmolality again. So that's what you need to know for ADH. Of course, it's very simplified, and we're going to go through this quickly. So you have CRH, which is going to increase the ACTH, MSH, and beta endorphins, which we said they all derive from the compound POMC. Then you have dopamine, which decreases prolactin. And the key thing you want to be aware of with any of these hypothalamic pituitary hormones is that they have subunits which sometimes can allow one of these hormones to trigger another hormone, and we're going to explain that in a second. So dopamine functions to decrease prolactin. And what ends up happening is prolactin, when it's being secreted, it actually increases dopamine secretion itself, so it inhibits itself. So this is called a short feedback loop, a very short feedback loop mechanism. So you can get asked what type of feedback loop, and it's very short. So prolactin is being secreted, dopamine is going to be increased, and then the dopamine goes to inhibit the prolactin. So prolactin effectively inhibits itself. The reason why this is important is because you have conditions where you have increased prolactin, such as a prolactinoma, and using dopamine agonists can help you treat that. On the other hand, you have some drugs like psychotics, antipsychotic drugs, which will decreased dopamine, and as a result you're going to have increased prolactin and the symptoms involved with that. You have GHRH, and that's going to increase your growth hormone. You have GnRH, and GnRH is important because that's what's going to stimulate the release of FSH and LSH. And these two are both suppressed by hyperprolactinemia. So you want to understand this when a woman has just given birth and she's breastfeeding, she's going to have high levels of prolactin, and she has this natural time of amenorrhea because of the hyperprolactinemia goes to inhibit the GnRH, so she's going to have decreased FSH and LH. One other thing you want to be aware of is how puberty works. So you have tonic GnRH analog like leuprolide suppresses hypothalamic gonadal axis. The key thing is that to understand what any of that means is that GnRH before puberty is kind of being secreted like this. Okay, when puberty starts to happen, it starts to become pulsatile. When that pulsatile activity starts is when puberty starts. So pulsatile GnRH leads to puberty and fertility. So we can utilize this therapeutically in people who we want to trigger the onset of puberty in them. So you also have, likewise the same way, if you want to stop anything, you would use tonic GnRH analog like leuprolide. Next, you have MSH, which increases melanogenesis by the melanocytes. Like we said, you're going to have this hyperpigmentation with Cushing's disease, as MSH and ACTH share the same precursor molecule. So we've said that already. And next we have oxytocin. So oxytocin is, remember, that's coming from the posterior pituitary. So we have your ADH and you have your oxytocin. Remember, ADH is also sometimes called vasopressin. You have your oxytocin, and oxytocin is involved with something called the milk letdown reflex. So it is responsible for causing the smooth muscle relaxation that happens in the myoepithelium of the nipple, and it causes the secretion of milk. So what makes the milk is going to be prolactin, and what secretes the milk is going to be oxytocin. So that's important. At the same time, it also causes contraction of the uterine muscles. So you're going to have an analog called Pitocin, and it's not mentioned here. They can ask you a question on Pitocin and understanding what is it doing. It's causing the uterine contractions during labor, so we can induce that using this analog of oxytocin. Next, you have prolactin. Remember, we said prolactin decreases GnRH, so you're going to have decreased FSH and decreased LH. And it's going to stimulate the lactogenesis. So you have a primary prolactinoma is going to cause amenorrhea, and that makes sense because it decreases GnRH. Breastfeeding is also going to increase prolactin. That's also going to cause decreased GnRH. So you're going to have delayed postpartum ovulation, which is a natural type of contraception. Next, you have something called somatostatin. Remember, I mentioned somatostatin before. It stops everything. So I like to think of it as somatostasis. So everything is going to be stopped, and you'll see that more with the pancreatic pathologies when we discuss them. But you're going to have your decreased as well as decreased growth hormone and TSH. It's also called growth hormone inhibiting hormone, and the analog is used to treat acromegaly. And we will discuss that because there's a lot of things you can use for somatostatin. Next is thyrotropin release hormone. That's going to increase TSH, and it's going to increase prolactin. So this is also very important because you might get asked in a patient who has hypothyroidism. So let's think about that for a second. If you have hypothyroidism, you have decreased T3 and T4, right? So that means TSH is going to continue to increase because it's not being turned off by feedback mechanism of the T3, T4 being produced. So that TSH is going to increase, and you're also going to have an increase in prolactin. So if they ask you, well, why do you have a patient who has galactorrhea or enlargement of their breasts or gynecomastia, the reason for that in a male patient is going to be because they have increased prolactin as a response to the increased TRH. That's an important question, and they love to ask about this. Next, you have growth hormone. So growth hormone, as the name implies, makes everything grow. It is also called somatotropin, and is secreted by the anterior pituitary. So here it says that it stimulates the linear growth and muscle mass. So everything is going to grow, and the growth is linear. So you're going to grow taller with growth hormone. So typically you're going to keep growing until the epiphysis starts to close, and then growth hormone effect on long bones is not going to take place. So now we want to ask ourselves regarding a pathology called acromegaly versus gigantism. So if you have an increase in growth hormone before this epiphysis is closed, then you're going to keep on growing taller. So you're going to have gigantism, and that's what's going to happen in children. But on the other hand, if the epiphysis has already closed and now you have a anterior pituitary adenoma and it's secreting growth hormone, but you've already closed your epiphysis, not available for long bone growth in this direction, then it's going to start to grow wider. So when you have this increase in width, you're going to have the clinical vignettes that you see with acromegaly, where you have a patient that is frequently complaining that they have increased glove size, increased hat size, because their hands are getting bigger, their head is getting bigger, their chin is getting wider, their teeth are getting spaced out. Those are the features, and that is the pathophysiology behind acromegaly. Now, the next thing you want to be aware of, let's go back to highlighting so that we don't forget that. So it stimulates linear growth, as we know, in muscle mass through something called IGF-1, or insulin growth like factor 1, also known as somatomedin C, and it's secreted by the liver. So they can ask you about IGF-1, somatomedin C, and where it is secreted. That is a possible question. It increases insulin resistance, so it's diabetogenic. Growth hormone, like we said, it's released in pulses to trigger. Released in pulses as well. So what does that mean? This is very important. So if it's released in pulses, right, you can imagine if I have a patient and I want to test them for any reason why their GH, if I'm expecting a pathology with growth hormone, well, if I test here or here or here during the day, I'm going to miss it, right, because growth hormone is pulsatile. So what I want is something more indirect, but it tells me whether or not there is a pathology with GH without risking this period of time where you are not able to see if there is a pathology or not. So for that, we use insulin-like growth factor 1. So insulin-like growth factor 1, irrespective of what's going on here, it's going to look like this. So if I check at any time of the day, I'm going to be able to observe if there is any pathology involved with growth hormone secretion. So if they ask you, and this is a trick question, a patient that looks like they have acromegaly, for example, they ask you, okay, well, what are you going to look for? And if you're going to look for a GH, that is the incorrect answer. The correct answer is to look for insulin-like growth factor 1, because that is the one that is going to be more stable throughout the day, and you won't have this blind window area here where you won't be able to capture really what's going on. And look, we've highlighted everything, so let's erase that. So you have increased, so it's released in pulses in response to growth hormone, releasing hormone, increased in secretion during exercise. Again, these are not really important to know, just generally the hypoglycemia is going to trigger that, and it makes sense because we just said that it's diabetogenic. So if there's hypoglycemia, we're going to have this increased insulin resistance. It's going to have its secretion decreased by glucose, which also makes sense. Somatostatin, like we said, everything stops with somatostatin. Excess growth hormone secretion as pituitary adenoma can cause acromegaly, as we've just described, and gigantism. Treatment is going to be somatostatin analogs like octreotide or surgery. Next is going to be your ADH, Antidiuretic Hormone. It's also known as vasopressin. Like we said, it's synthesized in the hypothalamus by the supraoptic and paraventricular nuclei, and it's stored and secreted by the posterior pituitary. So again, those are possible questions for you here. Synthesized where? In the hypothalamus. Where in the hypothalamus? Supraoptic and paraventricular nuclei. Where is it secreted? From the posterior pituitary, and what carries it? Remember, those are the neurophysin. Next, what is its function? So its name is called vasopressin, and its name is also called ADH. So as long as you don't forget that, you'll know that it has two main functions. So we have here regulating blood pressure through V1 receptors. So that's where we get the vasopressin name. So it works on increasing blood pressure by working on these V1 receptors. Next, through V2 receptors, it's going to go into the distal duct, and like we've said, it's going to insert these channels, these called aquaporin channels, and that's going to pull water back into the plasma. So here's your plasma and here's your urine. If I'm pulling water out into the plasma, I'm going to concentrate the urine on this end. So regulates blood pressure and serum osmolality through the V2 receptors. Primary function is serum osmolality regulation. So you're going to have decreased serum osmolality and increased urine osmolality. So just think of what is more concentrated. So now that I've put water on this side, this is going to have decreased osmolality. If I pulled water from this side, this one's going to be more concentrated, so you're going to have increased osmolality, and that can help us understand the pathologies later on. So the regulation is important. It's plasma osmolality and hypovolemia, which makes sense. So ADH level is decreased in central diabetes insipidus or increased in nephrogenic diabetes insipidus. So to understand diabetes insipidus, we're going to erase all of this. So we have a condition called diabetes insipidus. So for some reason, you have either a failure on the part of the kidney. That's a very ugly kidney. Okay, so you have a failure on part of the kidney to respond to ADH, or I have, this is a brain, no ADH being secreted here. So you can imagine if I don't have ADH, either lack of function or you're not producing it, right? You're not going to have this whole aquaporin situation. So the urine is going to contain large volumes of basically water, right? So you're going to pee it all out. So that's why it's called diabetes insipidus. So it's insipid, meaning it's a lot and it's non-stop. Okay? You're going to get a patient or a clinical vignette where somebody is aware that they are not drinking as much water as they are urinating. They become aware of the fact that they're peeing a lot and it's not equal to any of the input that they're taking. So that starts to look like diabetes insipidus. So like we said, there are two ways that diabetes insipidus happens. And don't think that there's anything related to blood sugar levels. This is a misnomer. It just looks like diabetes because you have large volumes of urine. And remember, in diabetes, that's happening because you have this osmotic pull of the glucose, which is going to pull water with it out into the urine. So that's what's happening with diabetes. It looks like it's diabetes, but if you test the sample for any sugars, you won't find any sugars. It's insipid. It's just large volume and low osmolality. So this is a misnomer, and don't think of anything relating to blood sugar levels. So that's the diabetes insipidus in brief, and we're going to get into more details. I don't want to overwhelm right away with that, but that's just in brief so you can understand what's going on here. Then you have nephrogenic diabetes insipidus. So one of the things that they've mentioned here is that in the one with the kidney version where you're secreting ADH normally, right, but there is for some reason a non-response happening on the part of the kidney, that can be due to a mutated receptor, for example, so you're not responding. So in one type of diabetes insipidus, the central one, you're going to have decreased ADH, while in the nephrogenic one, you're going to have increased ADH. Next is prolactin. So prolactin, we have already mentioned that prolactin is what makes the milk. So that's prolactin. And it's made in the anterior pituitary. So it stimulates the milk production in the breast and inhibits ovulation in females and spermatogenesis in males. By inhibiting GnRH synthesis and release, you're going to have decreased FSH and decreased LH as a result. It is structurally homologous to growth hormone. And this is a possible question for you. Next is that prolactin is secretion from the anterior pituitary is tonically inhibited by dopamine from the tubuloinfundibular pathway of the hypothalamus. So remember, we have the hypothalamus here. If you're anterior pituitary, you have a posterior pituitary. So you have prolactin is being secreted, and then from up here, when it senses that, it's going to secrete dopamine, and dopamine is going to go in and stop its secretion, the secretion of prolactin. So prolactin inhibits its own secretion. So we call that a very short feedback loop. And that can be a possible question. Thyrotropin release hormone increases prolactin secretion. We've already explained that. So if you have a thyroid condition, we have hypothyroidism, you have decreased T3 and T4. Now, normally, if you have normal levels of T3 and T4, they're supposed to go and tell this guy to stop secreting TSH, right? But if you have hypothyroidism, that doesn't happen. TSH is going to continue to rise. And because it has structural similarity, it's going to have prolactin-like effects. So you're going to have a patient who has gynecomastia or galactorrhea, and they have hypothyroidism. If they ask you why, is because you have increased TSH, and that's very, very important. Let's clear this here and go back to highlighting. So we've said that dopamine is going to inhibit the prolactin secretion. So I can take advantage of this therapeutically if I'm dealing with a prolactinoma. So prolactinoma have excess prolactin. So we can stop that by giving dopamine agonists such as bromocriptin, which is going to inhibit prolactin secretion and can be used to treat prolactinomas. Next is the other situation where you have antipsychotics. So a lot of the psychiatric conditions involve a lot of dopamine being secreted. So if you're giving somebody an antipsychotic, you're probably giving a drug that's going to decrease dopamine. So if I'm decreasing dopamine, I'm going to leave prolactin to be increased. So you're going to have increased symptoms of the increased prolactin. So you're going to have galactorrhea, gynecomastia, in patients that are taking antipsychotics. Next, you have your thyroid hormones. So your thyroid hormones are the T3 and T4, and the thyroid gland secretes mostly T4, and that T4 gets converted in the periphery to T3 by an enzyme called 5'-deiodinase. So if there's only one thing you want to read in this section is to know the two enzymes. The two enzymes are 5'-deiodinase, which converts T4 to T3 in the peripheral tissue. And the other enzyme you want to be aware of is, where did you go? Thyroid peroxidase. Those are the two enzymes. 5'-deiodinase is in the periphery, and everything else is going to be thyroid peroxidase. So if they ask you who's in charge of organification, who's in charge of coupling, who's in charge of oxidation, any of those functions that are going on in the thyroid gland, everything that's happening in the thyroid gland is the result of the thyroid peroxidase. Whereas in the periphery, you have 5'-deiodinase, which converts this guy into the more potent form, which is T3. So let's see here what we need to highlight. So you have the peripheral conversion can be inhibited by glucocorticoids, beta blockers, and PTU. This is important because when you have hyperthyroidism, most of the symptomatology is because you have this elevated thyroid, this elevated conversion of this potent form, the T3, and we can inhibit or minimize these effects by blocking this enzyme here. And PTU is important because it's one of the drugs that we commonly use, and it works both actually on the thyroid peroxidase and the peripheral conversion, unlike its other drug that we use called methimazole, and we'll get to that in the pharmacology section. That's just something to be aware of. You also have your beta blockers and your glucocorticoids, and those are important. You have something called reverse T3. It's a metabolically inactive byproduct of the peripheral conversion of T4, and its production is increased by growth hormone and glucocorticoids. So you might get asked the question where you gave glucocorticoids to a patient, and suddenly they have increased reverse T3, and you might be asked what happened there, and you want to know that that is due to a drug effect. That is a possible question. Like we said, everything else happens with the thyroid peroxidase. You have your oxidation, your organification of iodine, you have your coupling. So you don't want to overwhelm yourself too much with any of those details. Just know that everything that's happening in the thyroid is thyroid peroxidase. Anything that's happening in the periphery is 5'-deiodinase. Remember, the coupling is very simple to understand. Never really seen any questions on it, but you just have your DIT. So DIT is 2, so 2 plus 2 is 4. And then 2 plus 1, MIT is made out of 1 iodine particle, is 3. So 2 plus 1 is 3. The Wolff-Chaikoff effect is a protective autoregulation, and you might be asked about this. So basically, if you overwhelm the thyroid gland with a lot of iodine, it will try to protect itself from that by inhibiting the function of the guy that makes all the thyroid hormones, which is thyroid peroxidase. So it's going to turn off thyroid peroxidase. You're going to have decreased T3 and T4 production. Next, we're going to talk about the function. The function of thyroid hormone is important for everything all over the body. The most important thing you want to be aware of is brain maturation. So you need thyroid hormone for brain to mature, and if you have a patient who is born in an endemic area where there isn't enough thyroid hormones in the food and the mother just gave birth to this baby, they can be at risk of permanent brain damage. So I have a cause here of brain damage that I can prevent by supplementing or treating it very quickly. So the most important thing really is the brain maturation that you can get asked questions on. It's involved with bone growth, beta adrenergic effect on the heart. So all the symptoms that you see, the increased heart rate, all of that is happening because you increase the receptors on the heart. You not only increase the receptors, you have direct contractile effects. You have increase the amount of calcium that goes into the myocytes. You have increased sensitivity to catecholamines. There's a whole bunch of things that are happening with the beta adrenergic effects. It increases the basal metabolic rate, and they might ask you a question as to someone who is hyperthyroidism, why are they thin? Or why do they have a high metabolic rate? It's because of the increased sodium, potassium, ATPase, which increases your oxygen consumption. All of that. So the basal metabolic rate is the result of the increased function of the sodium, potassium, ATPase, and that can be a question. Blood sugar is going to be glycogenolysis and increasing gluconeogenesis. So you're going to have an increase in your blood sugar and breakdown of lipids, lipolysis. For many of these two reasons, especially this one here, it can be, some people do use thyroid containing drugs to, it can be misused as a weight loss type of medication. Next is your regulation. So we've said you have your thyrotropin release hormone is going to increase your TSH, and then that TSH is going to go to your thyroid gland, and then your thyroid gland is going to be stimulated, and then you're going to form and secrete the T3 and T4, and then they're going to go back and shut down these two. That is pretty much all you need to know here. In this diagram, however, we want to be aware of what's happening in the thyroid gland. We said everything is a byproduct of thyroid peroxidase. You don't need to overwhelm yourself. We said we have two therapeutics here, which is PTU and methimazole. If we take a look here, PTU also works on 5' deiodinase, which converts the T3 to T4. So PTU works on both thyroid peroxidase plus 5' deiodinase. That's your PTU. Methimazole works on the thyroid peroxidase. Now you have a channel that is very important. This is your iodine and sodium symporter. A symporter is going to transport two things in the same direction. So that's your symporter. And you might get asked the question on the effectiveness of radioactive iodine. Depends on what? Well, it depends on if I can get that radioactive iodine into the thyroid gland. So the success of radioactive iodine therapy, remember we can ablate a thyroid gland if it's hyperfunctioning, for example, and the effectiveness of this radioactive iodine depends on whether or not I can get the iodine into the gland using this symporter. So you get asked this question, this is the answer. Likewise, if I have taken something like potassium iodide, or I've taken something that is affecting or perchlorate or iodide, or certain foods that overwhelm this channel, that might decrease the effectiveness of the radioactive iodine. The same thing can also be used to explain why, if you have like a radioactive incident, like in the Chernobyl incident, for example, why people took iodine to overwhelm the gland. What do we mean by that? Just fill it up with another type of iodine so that the one that's coming in to destroy it is not going to do that. So you're just overwhelming the thyroid gland, filling it up with a different kind of iodine so that this symporter stops working and doesn't let in whatever bad type of iodine you don't want. Or in this case, you want something used to treat it, such as radioactive ablation. In this case, like we've said, it depends on this symporter. Next, you have your parathyroid hormone. And parathyroid hormone is kind of like the one hormone where you kind of learn to love it over time. It seems intimidating, but it's not really. And I will explain it to you as simply as possible. Parathyroid hormone is the main hormone that maintains calcium homeostasis. So, therefore, it makes sense that my trigger for its release is going to be anything that's going to decrease calcium. At the same time, we want to remember that PTH is PTH, also known as phosphate trashing hormone. So it's going to decrease phosphate whenever it's secreted, and it's going to increase calcium whenever it's secreted. So you're going to have increased calcium and decreased phosphate. And how it does that through different areas in the body. In the kidneys, it's going to do exactly this. You're going to increase the reabsorption of calcium and get rid of phosphate. Phosphate trashing hormone. Throw it in the urine, get rid of it, reabsorb your calcium. In the intestine, increase your absorption of calcium. In your bones, break down the bones, increase the absorption of calcium. The main goal is to elevate calcium. That's all you need to remember for parathyroid hormone. So it's going to increase your free calcium in the blood. That is the primary function. So in the GIT, we're going to increase your calcium absorption. In the bone, we're going to increase your calcium absorption. In the kidneys, we're going to increase the calcium reabsorption and trash your phosphate. That's important to know. Also in the kidney, it's going to increase the function of 1-alpha hydroxylase. So if you remember our vitamin D physiology, so in the kidneys, you have a hormone called 1-alpha hydroxylase, and that's going to convert 25 vitamin D, I'm just going to say that, to 125 vitamin D, and that's the active form of vitamin D. When I have this 125 vitamin D, this active form, that's going to go into the bones even more and pull out even more calcium, elevating the calcium levels in the blood. So that's how parathyroid hormone works, by increasing 1-alpha hydroxylase in the PCT. You might be asked where in the PCT, that's how, or where in the nephron system this is happening, and that would be in the PCT. So like we said, it's going to increase your calcium, it's going to decrease your potassium, decrease your potassium and increase potassium in the urine, which makes sense, and increase your CAMP. They know you're going to memorize this and this and this and this, and you're going to forget this one, and you're going to get asked on this one. So please don't forget, you're going to increase your CAMP, your urine CAMP, which makes sense because CAMP has a phosphate compound here, so that phosphate compound is also going to be trashed. So you're going to have your increased CAMP here. Next, you have your rank L. So inside the bones, you're going to have your osteoclasts. So these are the guys that are basically the macrophages that destroy the bones, and these are going to be activated by PTH by activation of this rank L ligand receptor. So increased rank L receptor is activator of NF-κB ligand secreted by osteoblasts and osteocytes. It binds the rank receptor on the osteoclasts, and it stimulates the osteoclasts to increase calcium and bone resorption. Okay, so we can quickly go over the PTH activity again, since that would be beneficial. So PTH activity, what is going to increase the secretion? Well, if I have low calcium, right, so I want to increase the calcium, secrete PTH. If I have high phosphate, I want to decrease it, so increase PTH. Or if I have low vitamin D, where we can increase the production of active form of vitamin D through the 1-alpha hydroxylase, which we just explained. So you have the 4 parathyroid glands, and this is important because they're literally embedded in the back of the thyroid gland. And this can be a problem during surgery for any thyroid surgery because you can remove these glands on accident. So I'm going to share with you a little tidbit of what happens. So if you remove these glands, the first thing you're going to get is features of hypocalcemia. And the first thing that you're going to see is going to be circumoral numbness. The patient's going to complain that they're numb around the mouth and numb around the fingers. That should clue you in that the patient's calcium levels are starting to decrease, and very likely that the 4 parathyroid glands may have been removed during some surgery. And the surgical tidbit I do want to share with you is, well, what do you do if you have like a thyroid cancer and you need to remove the thyroid gland along with the embedded parathyroids? Well, the truth is you don't actually remove them. You do leave like 1 or 2 of them behind with some amount of grams of the thyroid tissue. But you might get asked the question, well, what would you do with it? So if you've seen ENT, if you've attended ENT surgeries, you would know that what they do is they take some of what they see as the parathyroid, or what they think they can identify as the parathyroids that are embedded in the gland. It's hard to tell in the OR, but you take this material here that you thought are the parathyroids, and what they do is they mince it up. So they're going to cut it up and they're going to stick it somewhere. And you might get asked, well, it might not be asked on this exam or maybe in the CK exam, you might get asked, well, where would you place this now thyroid tissue, this parathyroid tissue that you need, right? Because it's very difficult, you can imagine, to keep calcium homeostasis on the level that the parathyroid glands do naturally. So it is definitely problematic because now you have a patient who's going to go into tetany because they don't have the calcium, and it can be problematic to maintain that homeostasis through therapeutics alone. It's much easier to just keep the parathyroids. So if you keep the parathyroids, you're going to mince it up and you're going to put it either, you have a choice between the neck, place it back into the neck of the patient, which makes sense because the patient's neck is open and dissected for you, versus sticking it somewhere else. So the correct answer is actually to stick it somewhere else, and typically that's going to be in the deltoid region in the arm. And the reason for that is because, well, we just said that you're taking parathyroid and there's some attached thyroid tissue. So if you just removed like a cancer, for example, there is a chance that the cancer can return to that area. So do I want to reoperate on a patient who had a previous neck dissection and the anatomy is completely destroyed, I can't tell what my planes are, and everything is fibrous and sticky and you can't get to anything, versus, well, I know that I placed this patient's parathyroid plus a little bit of thyroid tissue in their arm, for example. So if I do have an issue in the future with any pathology, it'd be a lot easier for you to operate on this area versus a neck dissection. So that's just a small tidbit for you regarding surgery. So again, calcium homeostasis, we said mostly that's going to be your PTH. The next way we maintain calcium homeostasis, although it's not important, it really isn't, is calcitonin. But why do we need to know calcitonin? Because you have about 10 different questions you can get asked about calcitonin, and we'll discuss them right now. So calcitonin is secreted from the parafollicular cells from the C cells of the thyroid. It works as the exact opposite of the as parathyroid hormone. So it's going to oppose the actions of PTH. So it's going to keep calcium down. But it's not as important because we know that if we remove the parafollicular cells from the thyroid, there isn't much of an effect on calcium levels. But why is this important for the USMLE is because you can get asked 100 questions on it. They can ask you, where does calcitonin come from? You want to know it comes from the parafollicular cells. What type of cells? The C cells of the thyroid. What does it do? We already said we're going to decrease bone resorption. But here they fail to mention something very important. There is something called medullary carcinoma of the thyroid. And this is associated with MEN conditions, MEN2B, or MEN2 conditions, any of them, MEN2 or MEN2A or B conditions. So you can get asked in a patient who looks like they have a thyroid carcinoma, and they will tell you, well, there's elevated levels of calcitonin. What type of tumor you're dealing with? You're dealing with MCT. They can tell, where does this tumor originate from? You want to know it comes from the C cells of the parathyroid, of the thyroid gland, sorry. So those are possible questions for you for the calcitonin part. So let's go over the highlighted sections again so that we've memorized and we've learned it properly. So you have your calcitonin. They can ask you where it comes from. We said parafollicular cells. What type of cells? C cells from the thyroid gland. And they do not mention here that it is part of the medullary thyroid carcinoma. I can use it as a marker for that, and you'll see later on when we discuss the tumors. Next is glucagon. So glucagon, remember we've discussed your pancreatic cells. You have your beta cells, you have your alpha cells, you have your delta cells. Beta cells give you the insulin, and the alpha cells give you the glucagon. So what do we need to know? They come from the alpha cells. They promote everything opposite to insulin. So they have glycogen. So how do we memorize insulin and glucagon? Because these things can get confusing. I like to keep things simple. Insulin, the goal is this. Imagine you have glucose in your blood, right? Now, I don't want that in my blood. I want it inside the cells so the cells can utilize it. So insulin is responsible of pulling the glucose from the blood into the cells. Glucagon will do the opposite. Glucagon wants as much energy as possible ready and stored in the blood for anywhere else to be used. So you have gluconeogenesis. We're going to formulate new glucose. You're going to have glycogenolysis, break down my stored glucose. Lipolysis, we can break down fats to make sugar. Ketogenesis, we can break down ketones to make sugars. So you're going to have elevated blood sugar versus what you'd have in insulin, where you have decreased blood sugar. There is a condition called a glucagonoma, which you need to be aware of, which makes sense that you would have a patient who has diabetes and a skin rash. And we will definitely discuss this as soon as we get to the pathologies of the pancreas. Next is your insulin. So insulin comes from your beta cells, and you have a lot of possible questions here on understanding the synthesis and where it's happening and what type of molecule you have. So if your pre-proinsulin is synthesized in the RER, that is a possible question. Cleavage of the insulin, so you're going to have pre-proinsulin, then it's going to get cleaved in the RER, and then you're going to have this molecule here called proinsulin. Proinsulin is made up of insulin plus the C-peptide here. And this is important. So natural insulin, what you naturally secrete in your pancreas, is going to have you're going to have two compounds that indicate that this insulin came from this pancreas. That's going to be insulin plus the C-peptide. And the reason I'm sharing that with you now is for you to understand something called an insulinoma and factitious disorder. So an insulinoma, you can imagine, is a condition where you have increased insulin. So if I have an insulinoma, you're going to have features of hypoglycemia. When I come to test this person, you're going to find that they have increased insulin. And because this insulin is increased endogenously, you're also going to have increased C-peptide. So you can see here it has increased insulinoma as well as sulfonylurea use. So what are sulfonylureas? Well, sulfonylureas are used to treat diabetes, and they are promoting the secretion of insulin. So if I'm promoting the secretion of the natural insulin that I have in my pancreas, naturally I'm also going to have increase in C-peptide. Now the other thing here that they do fail to mention in the first aid book is factitious disorder from psychiatry. So this can be a question and an interesting one, and has many steps because you need to understand. They can keep asking you questions, and then they'll ask you what kind of psychiatric disorder are you dealing with. And you need to know something called factitious disorder, also called Munchausen's. So factitious disorder is when somebody manufactures a disease, and the reason they are manufacturing it is primary. And this you need to differentiate from something called malingering. So there's two reasons why anyone would manufacture a disease and go and waste time and go to a doctor and waste resources and things like that. Number one is malingering, where the person is going there for a secondary gain. So malingering is secondary. So I'm going to the doctor, I just want to get a doctor's note so I can get a day off from work, right? Malingering, this person is not going to be cooperative with the medical exam, right? Because they're lying and they don't want you to know that they are lying. So they're not going to be very cooperative for you, and their gain is secondary. On the other hand, you have Munchausen or factitious disorder. And in this condition, you have a patient who has a primary gain of wanting attention, wanting care, wanting empathy, and they will be very cooperative with the medical exam because they want you to do these tests, they want you to book them in the hospital, things like that. And one such a way factitious disorder can present can be with somebody who's presenting features of hypoglycemia, and you check to see their insulin and C-peptide levels. You will find increased insulin and you will find decreased C-peptide. And you will know that this insulin did not come endogenous. They were taking insulin. Either they have diabetes and they took a bit over, and this can naturally occur, of course, with someone who has diabetes, or they have some access to insulin, and they know that this will land them in the hospital if they take too much in order to satisfy their needs for empathy, care, and time, and that Munchausen's that we've discussed. So that's an interesting step away from endocrine, and to understand the link with psychiatry section as well. Next, you have insulin. So how does insulin work? We're just going to go straight to the figure. So insulin is going to bind to a cell. Remember, I like to always imagine you have your glucose here, right? So here's your glucose, and you want to do anything to get it inside of the cell. So how do we do that? Well, insulin is going to do that for us. So we have a transmembrane receptor for insulin. You have alpha and you have beta receptors. So the alpha are on the outside and you have beta, they're transmembrane. It's up to you if you want to keep these details. You're not going to get asked about this. But insulin is going to go in, and it's going to have tyrosine autophosphorylation. It's not just phosphorylation, it's an autophosphorylation. So when insulin binds to this receptor, you're going to have two pathways that are going to be triggered. You have your RAS-MAP kinase pathway, and that's what's going to cause your cell growth, your DNA synthesis. Now, the more important one is this phosphoinositide 3 kinase pathway. So your P, I think I'm not sure if how they abbreviate this one, but this pathway is the one that is going to pull this glucose in from the blood into the cell for me to break it down and make energy for me to use. So it's going to do that by causing the excretion of these vesicles that contain GLUT4 receptors. Now these GLUT4 receptors are going to go in and embed themselves into the membrane, and now they're going to pull in that glucose for me. Likewise, when that glucose comes in, it's going to produce ATP, right? We're going to utilize our glucose, we're going to break it down, you're going to get your ATP, and it's going to close these potassium channels. That is going to trigger a depolarization, which is going to cause calcium to enter. And remember, calcium is always the molecule that's involved with exocytosis of anything. Neurotransmitters, it's calcium. Insulin is going to be calcium. So that entry of calcium is going to trigger exocytosis of insulin, so that insulin is going to be secreted into the blood as a trigger for that glucose that we just let in. So let's go through very briefly here and see what they want us to know. So it binds insulin receptors. Remember, they are tyrosine kinase. I'm only going to highlight what you might get asked about. So you have your tyrosine kinase. I'm going to highlight it in red. So it binds insulin receptors, tyrosine kinase activity, inducing glucose uptake. We said that through carrier-mediated transport. Remember, so it's going to break down and it's going to cause those vesicles that contain GLUT4, and then they're going to embed into the membrane. They're going to pull that glucose inside of the cell for me to use. Or they work through gene transcription, which was this RAS-MAP kinase pathway over here. So gene transcription, RAS-MAP, and then the phospho-PIP3, let's just call it that, kinase pathway, that's going to be the one that's going to cause the GLUT4 to enter the cell membrane and then pull in that glucose for you. The anabolic effects are going to be increased glucose transport into the skeletal muscle and adipose tissue. Exercise is one of the best ways to pull glucose out from the blood into the muscles for them to be used. Then you have glycogen synthesis, storage, triglyceride synthesis, sodium retention by the kidneys, increased protein synthesis. All of these things can be important for you to know, and this is important. So unlike glucose, insulin does not cross the placenta. You should highlight this. Okay, and I will explain in a minute. Before we do that, we have insulin-dependent glucose transporters. So you can get asked, this is an area of a lot of possible questions for you, the type of glucose receptor and where it is located. So GLUT4, when in doubt, just go with GLUT4 if you're dealing with everything except what is not GLUT2. Okay, that's the way to memorize this. GLUT4 is going to be everywhere where you want to pull in a massive amount of glucose into that area. So you imagine you have a large amount of adipose tissue in your body, you have a large amount of striated muscles, so we can quickly pull that glucose. Remember, glucose is not really the best thing in the world, right? It's going to cause oxidations, it's going to have a non-enzymatic glycation, and that's going to have issues in its own pathology. So you want to keep glucose not so high into the blood and put it somewhere else that it can be utilized or stored. So we have got your muscles, you've got your adipose tissue, that's going to be your GLUT4. Now, GLUT2 is bidirectional, and it's important because this is what's happening with GLUT2. So over here you have your GLUT2. GLUT2 are cells that need to sense the glucose status in the body. So you want to think of, well, I want cells that are going to be able to sense and do something about it, right? So they sense the glucose here, and the reason that it's high, so we're going to secrete insulin to pull glucose into the rest of the body. So I want to think of cells that are important, and they can sense the glucose and do something about it. So you have your liver and you have your kidney. So those are the two really the most important ones you want to know. So and your beta islet cells, of course, your pancreas, your beta islet cells, your liver, and your kidney. Next, you have your GLUT3, which is your placenta and the brain, and your GLUT5, which does your fructose and your spermatocytes. You might get asked about these spermatocytes. Next, you have your GLUT5, and like we've said, the GLUT5 is fructose transport, and that is the spermatocytes. That is definitely a possible question. Next, you also have your SGLT-I and your SGLT2. So these are sodium glucose transporters that are in the kidney. Let me just erase some of this here. You have SGLT1 and SGLT2, sodium glucose co-transporters in the kidney and the small intestine. And this is very important because we do have a class of diabetic therapy where we can block these, and that's going to cause glucose to be excreted into the urine. As a result, you're going to have glucose in the urine, and then that's also going to cause you increased risk of urinary tract infections and candida as well in those patients taking this class of drugs. All right, so the last thing we want to be aware of is that the brain prefers glucose, but it can use ketone bodies during starvation. And that's important for you to know as well. RBCs, I think we've mentioned RBCs as well. So we didn't touch on the GLUT1. So GLUT1 is going to be RBC. So you can get asked a question about that. Placenta is going to be GLUT1 and GLUT3. GLUT2, we said, is bidirectional. Anything that needs to sense and do something about it. Your pancreas can sense and do something about it. Your liver can do the same thing, as well as your kidneys. GLUT5, fructose for the spermatocytes, and SGLT1 and SGLT2 for for the kidneys. These are going to be sodium glucose co-transporters. We can stop that in the case of certain drugs for diabetes, but we're going to have a consequence of glucose in the urine, and that's going to predispose to urinary tract infections and candida. Alright, so I'm going to end this video section here. So the video right now is at just about an hour, and our next video is going to be completion from adrenal steroids and congenital adrenal hyperplasias. Thank you guys so much for tuning in on this video, and I will see you guys next time.